Welcome to Monday's Echo on the 12th of April. And today we have another important session where we're looking at TB prevention. And so I'm your host, Dr. Kozia Ziambo. This time I am doing this from Solwezi. We are, as the Echo team, we're trying to ensure that no province is left behind. And so we have Solwezi coming on board, and we're setting up an Echo hub here. And so very soon we'll be having different sub-hubs. And I know there are some teams in Wapula province with some teams in Kabwe where we're trying to establish Echo hubs. So just to make sure that we can still be heard, I can be heard. Can I just welcome St. Francis Hospital in Eastern Province? Would you like to say hello? St. Francis, are we together? Okay, that's fine. Can we hear from Dr. Zico Lunga? I see you have a team with you.
Hi, Dr. Ziambo. We can hear you loud and clear. I'm also in Solwezi at Zambia.
All right, wonderful. I should have been with you guys over there. And I can see UTH PCOE has joined in with Dr. Mputu.
Hi.
Hey, how are you doing?
I'm good. How are you?
Very well, thank you. Mr. Wedi
Nico, hi.
Fine, Doc. How are you? And Solwezi.
We are good, thank you. Dr. Mputu, we are ready for this one.
Okay.
I hope that Dr. LUNGU has also joined. Was having a bit of a challenge, but I hope that he has.
Dr. LUNGU, can you confirm if you're online? Is there?
Very much online.
Okay.
Okay, today we privileged to have the topic, TB prevention, and Dr. LUNGU will be presenting that. But with me at the hub, I'm joined by Dr. Mputu that is going to facilitate this session, and the other eminent scholars that will participate in this session. So without wasting a lot of time, I would like maybe to hand over to Dr. Mputu to take us through the program.
So good afternoon, everyone. I'll be your main facilitator this afternoon, and we have a program which will run and expected to end around 16 hours. So we'll start with a presentation, the didactic presentation from Dr. LUNGU. This will be followed by a small session of question and answers, and then after that we'll break out into various rooms. So there'll be an Eastern Province room, Saka, Western and Southern Province room. Each of these rooms will be joined by a particular expert to discuss the cases. The main sessions will be from the Lusaka case presentation by Dr. LUNGU, and then from there we'll follow it will be followed up by expert consolidation recommendations and some take-home messages. Then thereafter we'll wrap up the program and close. So without wasting much time, perhaps we should proceed with Dr. LUNGU's presentation. Dr. LUNGU, over to you.
Sorry, I got muted. Good afternoon, everyone, once again. And I would like just to say thank you to the organizers of this important forum. I want to say that today's presentation on TPT will take a different approach from what we may be used to, in the sense that we'll be sharing what are the key gaps and also sharing and also responding to some of the common questions that we get day and day on TPT. So as introduced, I'm Dr. Lungu Patrick, the National TB and Leprosy Program Manager. And I would like to say that I have no conflicts of interest to disclose at this point. As here shown in my presentation, we're going to look at TPT. What are the gaps? Sorry, my computer is freezing. I'm unable to move the slides. Bear with me.
Maybe you could just end share and then reshare.
Okay, let me do that. Okay, I hope this works out very well. So colleagues, this is, I wanted to share with you that as a country, we've done so well, given where we are coming from with regard to TPT. And this is how we are being perceived at a global level. And initially, Zambia was one of those countries which was lagging far behind in TPT, but today we are we're among the front runners. If you look at in East Africa, Southern Africa, Zambia is being ranked second to South Africa. Initially, where we were in 2018 and before, Zambia was actually below where we were at the level where Namibia is today. So this is information coming from USAID, and this is on the performance for the year 2020. So with regards to absolute numbers, we rank second to South Africa. But in terms of TPT completion, of course, we are among the top countries with TPT completion rates. This is the data coming from USAID, as earlier mentioned. Our desire is that everyone who starts TPT completes. So we should not be very happy with the 82% TPT completion rate. We should actually aim much, much higher. So the gap here is that not everyone starting TPT is completing TPT. So we need to put more effort in educating the patients and supporting them through the course throughout the course when they are on TPT. Another issue which needs to be brought out is the issue of TPT uptake in children. If you look at the gray bar, that one shows us where we are in 2020. The orange one shows us in 2019, and the blue one is for 2018. It is gratifying to note that progress is being made. If we compare the 3 years, 2020, we performed far much better than 2018 and 2019. And in terms of the total national uptake, as earlier mentioned, again, 2020, we performed far much better than the 2 preceding years. This is good, but is this good enough? Certainly not. You'll see it where we are today, that our TPT coverage in children falls far short of where we should be. And of the expected number That's about the 47,000 children living with HIV. About 34% have not accessed TPT. So the figures I'm sharing here is the cumulative figure of all the patients that have actually received TPT. This also includes the ones that received TPT in 2018, which some of them are beginning to qualify for a second round of TPT. So the 34% will actually, by the end of this year, will actually even go higher than 34%. I would like to share with everyone that at Central Stores, we have over 77,000 stocks of TPT that are enough to actually treat the 77,000 children living with HIV. That's the 100 milligram formulation. So what this tells us that we have more drugs than the need for people in children living with HIV. Of course, we have prioritized this population. So what we should also, I know this platform, there are also people coming from the TB fraternity. We should actually now start supporting children who have been exposed to bacteriologically confirmed TB with TPT. I'll share with you more reasons why. The reasons being that we are beginning to actually have a much higher number of children contracting TB. And not only drug-sensitive TB, but also drug-resistant TB, which is even far challenging to treat, especially in children. That also gives us the more reason why we should prevent TB totally in children, because it's very hard to treat this form of TB. So ladies and gentlemen, just this slide serves to highlight the gap that 34% of children living with HIV have not accessed TPT this far. So our efforts must go in ensuring that we cover up that 34%. We have enough commodities for the remaining 34%. Chair, you may wish to advise me when to run the poll questions. If not, I would like to proceed. So where are we with TPT in Zambia once again? So I would like just to share with you that we've expanded our options for TPT. And while we have expanded our options for TPT, our main option remains INH for both adults and children. I'm sure some of you may have already learned that the country now has 3HP. 3HP standing for 3 months of combined rifampicin and isoniazid. So with this new formulation, the patients will only take 12 courses, which means for the 3 months, they will take only once in a week. And that's add up to the 12 courses. And that's enough to protect them for the next 3 years. So I also just want to reiterate that our main formulations remain INH for both children and adults until a time when we have enough 3HP. At the present moment, 3HP is in selected facilities. For children, we have 2 options at present moment, INH and 3RH. So children, especially those who are not living with HIV, the HIV negative, we should use much of the RH. The colleagues here, Dr. Kozia will advise, but I think even 3RH is still indicated in children living with HIV. So the 2 molecules are available, and of concern is that the 3RH is not moving that much. So we should expedite and use the 3RH as well. I would like just to place emphasis that all clients on TPT should receive B6, and we should have no excuse for not putting these patients on B6 because the B6 is available. I would like to confirm that B6 is available. Thank you.
Talungu.
Yes, please.
Maybe we can do some poll questions now at this point.
Okay, please go ahead. Yeah, so colleagues, the poll question for the day, the first poll question is, patient X has been on ART for 2 years. On review, the attending physician realizes that the patient X has never been on TPT. He commences TPT and the patient receives 6 months. This question is not correct. It's been altered. Mputu, you can bring down this poll question.
So we go to the next question.
Yes.
May I read the question?
Yes, please read the question for the people.
Okay, so Miss can call her Mrs. M is on ART and completed ATT month ago. The attending physician calls for advice on when to start TPT. What advice would you give him? Are people responding?
Yes, they are. Quite interesting responses, Dr. Mputu, that we are getting.
I can see that.
Yeah, and I think it serves the purpose why we put up this question.
Dr. Mputu, you can end the poll.
Okay. Third question. I think there's a third question.
Yeah, Mputu, perhaps I would like to discuss this poll question at this point. The way I structured the echo was that immediately after the poll question, we discuss it. I don't know if you can share the results. Yeah, so colleagues, Mputu, have you shared the?
Yes, the results are on the screen.
Excellent. So colleagues, we've been getting a lot of questions on when TPT can be started post completing TB therapy. So if you look at Mrs. M, this is a patient who's living with HIV and has just completed TPT a month ago. And the attending physician wants to know when TPT can be started on this patient. So the principle behind is that when you're on ATT, you are actually, by the time you are completing 6 months of therapy, you are sterilized, you are fully sterilized. And what I mean by fully sterilized is that you have killed all the bacteria that was within you. And you are essentially free of any live mycobacteria. And that in itself gives you some good protection for at least 2 years to a year. And if you look at most of the TB relapses, they occur in the first 5 years of having completed TB therapy. So you are within the same, you are within the window where you are protected. Yeah, we're getting some feedback. So an individual who has completed TB therapy and they took it effectively and they've been declared cured, this particular individual may become at risk of TB when there is an episode of documented re-exposure. Let's say this particular patient, 6 months onwards, having completed TPT, another household member is noted to have active TB disease. It is there we can actually look at the history or the closeness of that individual who has been found with TB with Mrs. M. And if we note that they were living in the same household, possibly sharing the same room, the risk of reinfection is very high. If not almost 100%, we can be certain that Mrs. M has been reinfected with TB, and therefore she is at a very high risk. So in such a particular instance, Mrs. M can be restarted on TPT as soon as possible. If there's no documented re-exposure, Mrs. M, we will still have some high level of protection from the previous TB therapy that this patient took, and therefore only qualifies for TPT 3 years post completing ATT. So in this regard, if you look at the question, the responses, start TPT immediately, and we've been getting this question more often. I would like to say that practice is not informed by any meaningful evidence. Should there be a lot of evidence or convincing evidence, we will tend to that approach. But at the present moment, the evidence that we have is not convincing enough to warrant a public health approach in this regard. So in this regard, A is not correct. B, start TPT 3 years from now. That's a correct option. But if you look at C, start TPT when there is documented TB re-exposure before the 3 years protective period elapses. So in this regard, the best answer is B and C, which makes D the correct answer. I hope we can discuss this further, and I hope my explanation is clear. We can move to the next question. Dr. Mputu, we can move to the next poll question.
Yes, Dr. Lungu will move to the next poll question. So the question talks about the record completion status of TPT. So when do you record completion status when TPT is given for 6 months? A, do you enter completed? B, you only enter treatment completed when it's established so? Or C, enter in the remarks column that patient has been given 6 months? B and C are correct.
Thank you.
I think you can end the poll now.
Again, this is another common asked question on TPT. What do we enter in the records on TPT completion status when we have dispensed for 6 months? Remember, the outcome status there is very clear. You see that TPT completed, TPT not completed, lost to follow-up, and those other outcomes. So you only enter TPT as completed when you've established so. We are aware There are patients who have received the commodities for 6 months, but alongside, during the course of their TPT, they abandon it, be it at month 1, month 4, month 5, or month 6 itself. So in that regard, we cannot enter TPT completed when therapy has been abandoned before the 6 months has elapsed. By virtue of having dispensed 6 months does not mean patients have completed. So what we need to do is, let me share something. Let me share the register. Allow me to share the register for TPT. Tell my neighbors to stop making noise. Just bear with me. I will be.
Oh, you. So my young.
What's going on here? Yeah. So colleagues, this here is the TPT register, and here's what I was referring to, that there are 2 columns of interest to us: the outcome, and here in the outcome we indicate what the outcome was. If it's completed, you indicate completed, and down there you indicate the date when the patient completed. If the patient developed TB on the course of TPT, you say TPT stopped, patient developed TB, and you could put that in the comment section. TPT stopped, and the reason for stopping is that patient developed TB and patient has been commenced on ATT. So now going back to what is related to the poll question, where we are talking about TP, where we are dispensing for 6 months. So we should utilize this column for comments. We dispense today for 6 months. We should indicate that this patient has been commenced on TPT for 6 months. Either you can put 6 months dispensation, okay, or I think the guidance on what to put there will come through, but at this point, I would like just to guide to say dispensed for 6 months. Then for each month that we follow them up, either through SMS, through a phone call, or through the community structures, or any other time they come for review, we ask, and we are very certain that this individual has taken for those months, we update the register. If this patient appears in month 3, you indicate, you ask, did you take for month 1? You tick that. For month 2, you indicate up to month 3, you indicate that this patient has received TPT up to month 3. Again, if they come in month 6, which is a month where we are determining whether they have completed, or month 7, you indicate for the months that they have completed, for the months that they have received. And at the time of you are actually assessing for month 6 when they are full, this is when now you say TPT completed. But without that evidence of having checked with the patient whether they took the ATT, we cannot indicate that a TPT completed by mere fact that we gave 6 months. It is very important that we track this indicator very correctly so that we can intervene correctly. So our data should reflect the correct situation on the ground so that we can intervene correctly. So with regard to the poll question, but if you can put it back again.
can see Dr. Lungu.
Yeah. So thank you very much, Dr. Mputu. So the correct answer here is D. So you should only enter treatment completed when you've established so, by confirming with the patient, and C is guiding us that we should actually enter in the remarks column that we've given TPT for 6 months. So the correct answer there now is D. Are we together? I hope we will have a very good discussion on this. So allow me to continue with the presentation.
Dr. Lungu can proceed.
Thank you. Again, I'm having a similar challenge. Okay, great. So ladies and gentlemen, I want just to share with you that your efforts are yielding results. And not only from TPT, but also from ART measures that we are putting in place. So I want to share with you some of our analysis from the TB program. And bear with us, we kept the HIV prevalence constant. We are aware that there is a fall in the HIV prevalence, but we kept it at 11% in this estimation. That's the black line that you are seeing. The dotted green line is showing us our scale up of TPT. The blue line is showing us the total TB notifications over the 4-year period, starting from 2017 into 2020. And the broken red line, or the dotted red line, is showing us the TB HIV. So that's the TB HIV co-infection. And what we are seeing is that our TB co-infection rate for Zambia is going down, and it started going down in 2018. It is corresponding with the period in which we started the scale up with TPT. So essentially, we can say that there are early benefits from TPT, and TPT is impacting positively on reducing TB among people living with HIV. But we are aware that TPT is not doing this alone, but doing it alongside ART and the high viral load suppression that the country is recording. So this slide serves to encourage all of us and to motivate us that we should continue scaling up TPT, because it's actually having a positive effect on people living with HIV by reducing TB incidence among people living with HIV.
Dr. Lungu,
Yes, please.
we are eating through the breakout room time.
Okay, so let me wind up. I think I've actually finished. This is my last poll question. I want to say, I think this poll question is equally important. Just to correct, so patient X has been on ART for 2 years. On review, the attending physician realizes that the patient X has never been on TPT. He commences TPT and the patient receives TPT, actually not for 6 months, but for 2 months. So where the 6 months, please put 2 months. On review, okay, yeah, it is very correct what it is say. This patient was received or was given TPT drugs enough for 6 months, and that was INH and B6. But on the subsequent review, this patient informs the nurse that they only took TPT for 2 months. So what will be the correct actions to take on this patient? So those are the questions that we have. So I hope you got the reading of the question. Patient has been on ART for 2 years, and we give this patient TPT for 6 months. But on return, this patient tells the nurse that she only received TPT for 2 months. So the 4 months, this patient did not receive. So
We already received some responses of LUNGU.
Excellent.
Yeah, so let's see, give him a few more seconds. Then from here, we go straight into breakout rooms.
Yeah.
Perhaps we can stop the poll for the sake of time.
Yeah, please stop the poll. So guys, ladies and gentlemen, the take-home message on this question is that we should screen this person for TB. And if they don't have TB, restart TPT immediately. And also we should cancel this patient and understand why they stopped TPT. So A is correct, B is correct, and D is correct. So the best answer actually should be E, except it read C. So this poor question, I think we will not judge, but just to say that the key steps: screen for TB, cancel the patient, and understand why they stopped, and immediately they are willing to restart them on TPT. Putu, we can move to the next session of our echo.
So Dr. Lungu, perhaps there's someone who has a burning question for you. We can allow one or two questions only.
Thanks. Okay. Please allow them to ask.
So Peter has raised a hand.
Yeah.
Hello?
Oh, kulimfula, yeah, kunota kuli.
Putu, there are some hands that have been raised.
Okay, so there's Nathan Nyangwe. Nathan Nyangwe, can you ask your question?
Okay, thank you very much. I hope I'm loud and clear.
Yes, you are.
Thank you very much, Dr. Lungu, and thank you, everyone. It was a good presentation. So one of the things I really noticed from the presentation was an emphasis on provision of pyridoxine in the process of providing TPT. But I noticed that in the guidelines, the Zambia Consolidated Guidelines for Treatment and Prevention of HIV infection, on page 110, on the criteria for TPT B6 and also cotrimoxazole, it shows that those that have got a weight of 14 kg and above, it says pyridoxine B6 not applicable. So just wanted to appreciate the technical guidance, because we've noticed that some on the ground are not giving TPT because of that. Others are giving. So Doc, what's the guidance on that? Thank you so much.
Yeah, so Nathan, thank you very much. What I would like to just say that I will verify that write-up on what is contained in that document. Otherwise, the guidance still stands that everyone, be it children, even those who are below 5 years, those who are 1 year, who are likely to even be less than the 14 kg, we still give the B6. So I think perhaps we need to correct that, what is obtaining in that document. I think the beginning point is to verify, and secondly is to correct that write-up. So the guidance, I think, for all of us to take that everyone on TPT should be on B6. For as long as they are on INH, they should be on B6. Thank you.
Thank you, Dr. Lungu. I hope, Nathan, you are satisfied with that response.
Yes, thank you very much.
Okay, we can now move to our breakout rooms.
Dr. Mputu, there are a few more questions. Maybe we can, we have a bit of time. You can just quickly ask a few more people. There are a few more people that have raised their hands.
Okay, there's a Sefula Chimpwembe.
Yes, Doc, I need your clarification. In a situation whereby you start this child for 3 months on TPT, then he comes back for refill, then at the time he comes back, there is no, we run out of stock. Then in the next 2 weeks, the facility supply. So should we restart the client or he maintains? Thank you.
Thank you very much. So I think this is another question which I should have actually tackled. So if someone who's received 3 months and beyond, if there's any interruption for less than a month, that person should just continue. So there's no need to restart and extend the period of TPT. So in a case that you've given, just restart and still end at 6 months. But by any means, we should avoid interruptions in the course of TPT. And this is where I think a point to emphasize to everyone that we should manage our commodities very, very well. One of the things that I think we will be coming to the grassroots for is that we want now to derive facility level targets. So you should know your number of patients that you are targeting for TPT, and you should secure commodities for that number of patients that you anticipate on a weekly basis, on a monthly basis, in a quarter, and in a year. So that's my guidance. So in that instance, please continue TPT for as long as the interruption is less than a month, when someone has received 3 months of and by any means, let's avoid interruption and let's manage our stock very, very, very.
Thank you. We can get one more question from Maramba Health Center.
Hello, good afternoon, Doc. Kabala Evans from Maramba. I think one of the challenges that we've noticed is that on the supplies, you would have isoniazide, but most of the times there's a shortage of B6. What could be the stock status for B6 now? Was like we speaking right now, we have the stocks for INH, but B6 is a problem.
Okay. Thank you, Captain.
Submit.
So the stocks of B6, I'll speak from the level of the central stores. We have enough B6. The last time we checked the stocks was a month ago, and it was actually in excess of 200, enough to treat over 200,000. Remember, reach out to the province, and if the province still does not have, let us know here at HQ. We can put in some mechanisms for you to receive the B6. The same guidance applies for all the facilities and districts that may be experiencing shortages in B6 to reach out to the province, to the provincial pharmacists, and where the provincial pharmacists cannot resolve these issues, please reach out to us. As far as we are informed, we have enough stocks at central stores and also at the provincial level. So things can be coordinated more effectively at that level, district and the provincial level. Is that okay, Malamba?
Maramba Health Center, I hope you are satisfied.
So, Dr. Mputu, we can allow Mr. Kampamba to speak.
Yes. Yeah, I was going to call him next. Davis Kampamba.
Okay.
Is this the Davis Kampamba?
Yes.
Okay.
Good afternoon, team. And thank you, Dr. Lungu, for a wonderful presentation and handling of the questions. So I'm just on the page that Nathan had referred to, which is on page 110. So if you check the pyridoxine, that's the vitamin B6, and then also the INH CTX vitamin B6. That's the description of the drug in the first column. If you go in the second column, we have the strengths of these two molecules. Now, take note, it is a 25 milligrams strength. So the restrictions in the not applicable between 3 to 6 and 6 to 10 and 10 to 14 relates to the strength of this particular molecule, not the drug per se, because we have strengths that are appropriate for these weight bands. So that is the explanation that I can give in this particular case. Over.
Thanks, Davis.
Clarity, and thank you for your proactiveness. Well done, Davis.
It's nice that you're moving around with the money. So, can we now move to breakout rooms? Can we move to
yes, I think we can move on to the breakout rooms. I hope Eastern Province, you are ready. Maybe we can hear if you're ready, Eastern Province, Western Province. Can we get a confirmation?
We are ready, Dr. Kozia. Western, we are ready.
Okay, Southern.
Southern, we are ready as well.
Osaka.
We are ready.
Awesome. So IT, maybe you could take us now to the breakout sessions. For those that have got new device, the updated version, you can actually go to a box that will appear on top to say breakout rooms. In case you go into a wrong room, you can still manage to actually go to the breakout rooms and then you join the correct one. So see you on the other side.
Anyone from UTH Hub? We didn't get the pop-ups for the breakout rooms. And it appears a number of participants are stuck in the on this page.
Okay, hi Shepherds, which room are you going to?
Eastern Province.
Eastern Province?
Yes, please.
Okay, okay, let me send you Shepherd.
Kindly assign us also to.
Okay, that's why it's important that we all rename our devices. So Susku, that's Western Province. Right? Okay, okay, thanks.
You can take me to Lusaka Province as well. It's Nebat Rogers.
Nebat Rogers, okay.
Yes,
Okay, noted, Nebat. But please, let's rename our devices because it becomes difficult to assign people and it takes a lot of time. So if you just put your name, it's very difficult to assign you to the room of your choosing.
Hello, Esther Kaimba here. I need to be assigned to Lusaka Province.
I'm sorry, who's this?
Dr. Esther Kaimba from Mehari. I need to be assigned to Lusaka Province.
Dr. Esther Kaimba. Okay, just a second, though.
Yeah. Hi, this is Samson Chitandua from KDH Western. So if you could allocate me to Western as well.
Samson Chitanda.
So there's Kendo Chongwe, Lusaka Province.
Siminga Mavuto, that led me to Eastern Province. Siminga Mavuto.
Sorry?
Eastern Province for Siminga Mavuto.
Okay, okay, I'm sending them.
Good afternoon, Moses Hamangawa, Eastern Province, please.
58, 92, 52.
And John Zimba, Eastern Province. Nyanga Renford, Lusaka Province.
Wakinaka fundi. Libera.
Eastern Province for Moses Hamangaba.
Please, let's rename our devices because assigning takes a long time to do. So those who haven't renamed, it's difficult to keep track and assign at the correct time. So please bear with me, I'm still assigning. But please rename your devices to the provinces you want to join to be easier to assign you that way.
So in order to rename our devices, we have to log out?
No. You can just go to participants. When you go on participants, hover over your name, you'll see like 3 dots. And then you can kindly rename your device.
Sure.
I've just renamed mine, please. You can take me to Eastern.
John Zimba Eastern Province have just renamed my device.
Hello.
Yes, please.
Nyanga Province. I've named my device.
Sorry?
So
Nyanga?
just from renaming my device,
Okay, okay,
Lusaka
okay, thanks, Nyanga. Let me just assign you.
Oh, boy,
you can also assign me. I've renamed my device as Western Soseko.
Okay, okay, thank you very much, sir. But for Western Susiku, which room are you in currently? You're not assigned. I'm looking for you, but I can't see you.
Like I'm in the main.
Okay, Susku Western.
Mlenga Moses, Copper Belt.
Sorry, I didn't get you. The line was breaking. Sorry?
Hello. Kindly take me to Eastern Province, John Zimba.
John Zimba. Okay, I'll look out for you. Thank you.
Hello, I'm still waiting. Dr. Kaimba here. Yeah, Lusaka Province.
Dr. Esther Kaimba. Okay, I'm looking for her.
I was assigned to Western Province, I think, but I'm in the main room.
You're assigned to Western Province, but you'd like to go to Lusaka?
Yes.
Okay, okay, thanks. At least I know where you are now. So let me look for you in Western Province and then assign you to.
Okay, thank you.
You're welcome, ma'am.
Sorry, if you could assign me to Western Province, Sam. Yes.
Hello, this is Kendall. My device is named at Kendall Lusaka. You assigned me to Western Province. Please put me under Lusaka Province.
Hello? Hello?
Yes, please.
Yeah, Sefola Western Province. Can you assign me to Western Province?
Which room are you in currently?
At first I was in Southern, but I logged out, then I came to the main.
Okay, so Sefula Western. Okay, thank you.
Hello.
Okay,
John
okay.
Zimba.
Sorry?
Hello.
John is still waiting in the main room. I should be taken to Eastern Province. John is in the Eastern Province.
Hello.
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 Chatonda.
Hello?
Chat.
Yes, please.
Good afternoon.
Someone called out my name.
It's me calling you, Kunda.
Okay, okay.
The Western Province, I was in that group, but they didn't have a presenter. Then my phone disconnected for a while. Can you take me to Western Province? I see if they still have no presenter.
Okay, you're currently in the main room, right?
Yes.
Okay, so I take you to Western. Okay, sending you right now. Done.
Thank you.
Welcome.
The same here. You can send me to Western. Good afternoon.
Have you put your correct regions? Because it's difficult to just.
Yeah, I was also in Western Province, but I was logged out. Okay, thanks.
Okay, just kindly rename your devices. So if your name is, if you are only putting your name, it's very, very difficult and it will take a lot of time to assign to the correct room.
Hello, good afternoon.
Good afternoon, sir. How are you?
I'm all right. I'm in the main room and my device is renamed as Copper Belt, Harrison Copper Belt.
Okay, so currently we are only breaking out into 4 provinces. That's Southern, Eastern, Western, and Lusaka.
Oh, okay.
Yes, please.
So I don't know where you're going to assign me.
Okay, okay, no problem. Let me just randomly put you in a room. Thanks.
Hello? You can take me to Lusaka Province, please. That's Kiembe there.
Kiembe, Matthews, where are you going?
Lusaka Province, take me to Lusaka Province.
Which room are you in right now?
Main room.
Kiembe, okay, okay.
Good afternoon.
Good afternoon, Moses Mulenga.
Yes, I'm still in the main room. Can you kindly assign me to Lusaka Province?
Good afternoon. Can you assign me to Western Province? This is Congo.
Okay, okay. Duly
Congo,
noted.
we are still in the main room.
Oh, yeah, still in the main. Yes, okay.
Yes, please.
So the names are in alphabetic order. I'm just trying to look for your name. That's yes.
Congo.
Yes, please.
See Congo.
But I can't seem to see you in the main room. See Congo Western.
It's written Congo Western.
Yes, I can see you in the main, but not on the unassigned.
Yes. Okay, because I was trying to join and it's once I join, I press join, then it goes off. So I get logged out.
I see.
Mm.
Okay,
Good afternoon.
I'm looking out for your name.
Okay.
Good afternoon.
Good afternoon, thanks, sir.
I'm Innocent Mukupa calling from Mufumbo, Northwestern Province.
Okay, Mufumbo, Northwestern, okay. So for Northwestern, we are currently only breaking out into the 4 CDC regions. So if you can bear with us, we'll just assign you to a random room. We are yet to officially.
Actually, I'm still waiting. Assign me to anywhere. Okay, it's the same information we are reading.
Okay, thank you. I'm assigning you. I've assigned you now. Thanks.
Hello, Chair.
Good afternoon, Hansingo.
Yes, Hansingo from Namwala District, Southern Province.
Okay. You hadn't indicated where you were on your name, so it's difficult to assign to a correct room. So now I've assigned you.
Okay, thank you.
Okay, thank you.
Hello, good afternoon, Chair.
Good afternoon, please.
This is Mushiri from Central Province,
Sorry?
specifically Kabwe. Mushiri, we're from Central Province, Kabwe.
Okay. Which room would you like to go to? Because we only have 4 provinces, as you're aware. I'll take you to Lusaka. That's fine.
All right, no problem.
Welcome, sir.
Okay, thank you.
Hello.
Hello, this is Chanza James. Kindly assign me to Lusaka. My network is very unstable. I keep dropping off.
Okay, Chanza James, Lusaka. Okay, done. Then John Zimba, just a second. Let me just quickly send you. J Zimba, John. John Zimba, which room are you in currently? I can't seem to see on the unassigned.
Main room, I was in Western, but I came back, so I want to go to Eastern Province.
John Zimba, yeah, in Western currently?
I was in Western, but I went back to main room.
Okay. The thing is, I can't see you in the main room, so I'm just trying to check all the rooms. So please bear with me, sir.
Okay.
Let me just quickly look for you.
Dr. Mputu.
Dr. Mputu is in a different room. This is the IT focal point person, Mvula.
Okay, Mr. Mvula.
Yes, please.
I was initially in the Lusaka group, but I think the system blocked me out.
So are you going back to Lusaka?
Yes.
Okay, done.
Okay.
Madam Esther Kayenga, I've seen you again, but which province did you want to go to again? Because it's not showing which province you're supposed to, you haven't renamed your device.
Oh, okay. It's supposed to be Lusaka province.
Okay, done. I've assigned you.
Okay, thanks.
I'm still in the main room. You can take me to Lusaka province, please.
Lusaka
Kiembe.
province, Kiembe. I can't seem to see you in the main room, Kiembe. Did you at some point drop off?
Yes, I dropped off from Western province. There are no presenter.
I see.
Yes.
Okay, let me just quickly look for you because in the unassigned, I can't seem to see your name. So I'm trying to see which room you're in so I can.
It should be the main room.
Kiembe, which room did you say you wanted to go to?
Lusaka province.
Okay, so I've noticed you're in Western province that you're not in the main room. I've moved you. Hello?
Okay.
Yes. I've even lost track. I'm trying to assign people to rooms. They're just giving names without, so I don't know. Maybe you can advise. Okay, 10 to. Okay, no problem. Thank you. Yeah. Is there anyone else who may have dropped out at some point and is not in the correct room? Please let me know. And please let me know which rooms you're currently in, because we have 400 or 500 connections. That's why it's taking long to assign. If you let me know the room you're in, then I'll assign you to the correct room. So I can see Pretty Shimumba has inboxed me, but I'm not even sure which room she's in. So now I have to physically check the 4 rooms. Pretty Shimumba, which room are you currently in? So Pretty Shimumba, you're not in the main room, you're in Eastern Province. So now I'm moving you to Lusaka. So please check the rooms you're in for me to assign you to the correct room. It takes a while to check all the rooms and then start reassigning you.
Nothing. No. Bamukange bali mu byanga bakumanya. Bamukange bali mu byanga.
Okay, so I'm closing, so it's minus 60 seconds. Thanks. Okay.
It's easy when you're watching with the
Hi, once again. So we are back in the main session. Lusaka province should be ready now to present for the next 5 minutes or so.
Yes, Dr. Mputu.
Yes.
Okay, I'm Dr. Lungwabungu from Chilenje, Lusaka province. So just to summarize, we had the case of a male 49 on ART for over 10 years, currently suppressed on second line with history of smear positive pulmonary TB in 2009. He completed ATT after 6 months. Currently, he has symptoms of peripheral neuropathy that have been on and off for the past 5 years and are relieved by taking vitamin B6 and pain medication. He currently has no TB symptoms. Of note is that he had elevated liver enzymes in 2014 and 2019, which were over 5 times the upper limit of normal. He's a chronic alcohol abuser, though he's now trying to cut down on his intake. So the first question was, how best can we manage a recipient of care with chronic alcohol abuse, and then they're also eligible for TPT? So we stated that our patient needs counseling and that DOT strategy will be helpful for him. Then the priority will be to resolve the chronic alcoholism. Then our expert stated that our patient needs rehabilitation and that alcoholism itself is a risk factor for pulmonary TB. So he has alcoholism and HIV, which are both risk factors for him to develop pulmonary TB. Then for the second question, in a patient that has history of elevated liver enzymes but no access to the current LFTs, what parameters will be helpful before we initiate TPT? So we stated that in a case where you're not able to do those tests, you can refer to a center where they can do a hepatitis profile, liver function tests, and abdominal ultrasound. Then we stated that we needed to investigate the cause of the peripheral neuropathy. We needed a client-centered approach where we can challenge his socioeconomic issues, especially the alcoholism. Then our expert advised that bedside clinical evaluation will be very helpful, where we can evaluate for encephalopathy, liver derangement, where we can have jaundice, disoriented mental status, hepatic flap, and palpate for hepatomegaly. If none of these are present and we're unable to do our LFTs, we can go ahead and initiate those that are eligible for TPT. Thank you very much, Dr. Mputu.
Thank you for the summary, Mwenya. Yeah, so I'll just add the one comment on your, I don't know if the experts had given you this input. Remember that people who take chronic alcoholism tend to have a lot of nutritional issues, micronutrient deficiencies. So you may also want to look into vitamin B12 deficiency. That could also explain the ongoing peripheral neuropathy in your patient. That's what I wanted to add.
Thank you very much. We've taken note.
All right. Dr. Lungu, you have about 2 minutes to give us a consolidation of your presentation and some take-home messages.
What was that? Were you calling on me?
Yes, I'm saying you have about 2 minutes. You can give us some take-home messages on your presentation.
Yeah, thank you very much, Dr. Mputu and everyone. I just want to say that it's been a very good interaction. The take-home message I want us to bring out is that let's improve our record keeping for TPT. It's going to inform us very well in terms of our deficiencies and areas where we need to improve. And it's going to give us a true reflection on TPT completion rates. With regard to TPT initiations, re-initiations for those who have completed ATT, it is as we guided, 3 years post completing ATT. And for those where there's documented re-exposure to TB, let's not hesitate to restart them on TPT. And we should document that adequately in our files, that we are reinitiating TPT because there's a documented re-exposure. Those are some of the key issues that we need to actually take care of. And one of the things that we all need to just remember is that we have done so well with TPT, more especially in adults, but let's also scale up TPT in children. They too are at a high risk of contracting TB, both children living with HIV and children who are exposed to bacteriologically confirmed TB who are HIV negative. Those are the take-home messages I wanted to bring, and just to thank all of you for the great work that you are doing, and please continue. Bye-bye.
Dr. Lungu, thank you very much. I think we are coming to the end of today's meeting. There's been a lot of teaching and learning from within the network. As we wrap up, I would like to appeal to everyone. I know Dr. Lungu has said that we are doing so well. We are number 2 now in South Africa. I think that shouldn't be the case. We should be number 1. So as we go back to our facilities, let us aim to get South Africa towards TPT initiation and completion rates. So with those remarks, I think we can close today's session until we meet next time. Thank you.
Thank you so much, Dr. Mputo. Maybe just a few announcements that so next week we are going to have another important session. We'll be talking about, it will be on DSD, and this will be provincial led. Another exciting moment that we hope we'll be able to manage as provincial led. So thank you so much, Dr. Mputo, for being with us. Thank you so much, Mr. Silomba. Thank you, Dr. Lungu. We want to thank all the participants that joined the network this afternoon. We appreciate those cases that were presented in the provinces and the facilitators. Thank you very much. And so we also want to encourage the network to update their Zoom applications, because we want to stop using the IT to assign us. So if you update your Zoom application, each time there's a breakout session, you can actually choose which room you can go to. So that's where we'll be moving on to next. So we look forward to seeing you next week. Have a very good week. Thank you so much again, Dr. Mputo.
Thank you so